We presented RETAIN at GU ASCO 2023, and this was a phase 2 non-inferiority trial for bladder cancer patients with muscle-invasive bladder cancer, where we tried to spare cystectomy or any bladder-directed therapy, such as chemoradiation, for patients with muscle-invasive disease by trying to select patients who have an excellent response to neoadjuvant chemotherapy. So the study was a non-inferiority design where all patients with muscle-invasive bladder cancer, T2 to T3, were enrolled and were treated with neoadjuvant chemotherapy, accelerated MVAC, for 3 cycles. While they were getting treatment, the tissue from the original biopsy was sequenced, and we were particularly looking for 4 mutations: ATM, FANC, ERCC2, and RB1, which were all known to be associated with a really good response to neoadjuvant chemotherapy at the time of surgery. And after chemotherapy, if a patient had a complete response on imaging, on cystoscopy, on cytology, and had one of those 4 mutations, they were allowed to undergo surveillance rather than surgery. So they were monitored closely with cystoscopies, with imaging, with blood work, but their bladder was not removed and they did not have radiation. The rest of the patients who did not have a complete response or who did not have a mutation then went on to standard of care treatments, mostly a cystectomy. And the patients were all followed out, and the primary endpoint was the 2-year metastases-free survival for the whole population. And we were looking to hit a certain bar for our point estimate of the 2-year metastases-free survival and our confidence interval to say that this approach, where we are sparing cystectomies in patients, is non-inferior to the standard of care. The key results were that the 2-year metastases-free survival was around 72%. And the way we designed it, the 95% one-sided confidence interval was approximately 62.5%, just slightly shy of the 64% mark that we needed to hit to meet our primary endpoint. So the trial did not meet the primary endpoint of non-inferiority, and therefore that is what we reported and stated that this certainly cannot be adopted as a standard of care at this point. However, we also showed that approximately 46% of patients who went on to active surveillance have, at the 2-year mark, been able to retain their bladder, have not developed metastatic disease, have not died. Some of them have needed to have intravesical therapy, but quite a few were again able to keep their bladder intact, which is a big positive for patients. We learned that most patients on active surveillance who did recur with metastatic disease, of which there were 10 patients, 80% of them had actually local recurrence first. So they had either non-muscle invasive or muscle invasive recurrence first before their metastatic disease. And that's an important consideration as we think about in the future what to do with patients in whom that occurs, where we're suggesting that you need to be very aggressive in those situations and undergo immediate cystectomy. The chemotherapy was well tolerated, and patients certainly appreciated not having a cystectomy. So these results are, I think, hypothesis generating. They are one of a few trials in this space where we're trying to spare bladder therapies. So there's another trial presented at GU ASCO by Magalski, who had a similar, not the same, but a similar approach. And so the work will have to be put together with that trial as well as several ongoing trials to figure out how we better select patients for this bladder preservation. And I think it'll involve ctDNAs, urinary biomarkers, and better imaging, such as with MRIs, to really go on to the next generation of trials. So there's a few ongoing trials. There's one by Alliance, one called RETAIN II at our center, that are examining this question. And so this is sort of building a foundation for this approach.